Morning, everyone. I'm Dr. Cao from the First Affiliate Hospital of Harbin Medical University. Thanks to the introduction from Dr. Chen. And today I'm going to share the topic of interpretation of the advances in intracoronary imaging in 2025. As we all know that the conventional angiography only gives an luminous silhouette, which cannot be precisely tells us of the accurate vessel size or the plaque composition, cannot tell us the precise and accurate plan of the strategies how to perform the PCI. And the functional assessment like the FFR, Professor Yu just mentioned that can only tell us whether this lesion is ischemic or not, cannot tell us whether this one, how to treat it or how to treat it good. So the intravascular imaging can fill the both blanks, both the anatomy and the biology. And on this chart, thanks to the courtesy of Dr. Gary Mintz, we can see that this PPT indicated that registry study RCTs and meta-analysis published 2020 ago, which indicated all the intravascular imaging landmark studies that pushed and proved that intravascular imaging guided PCI is superior to that of angiographic guided PCI that can make a better prognosis of the patient. So let's have a quick go through the guidelines before 2023. We can see that on year 2018, the guidelines from ESC indicated that the intravascular imaging could be considered, for selected patients to operate stent with a recommendation level of class 2A. In the year 2021, both the European guidelines and American guidelines with a level 2A recommendations for the cases with unprotected left main disease, stent failure, and ACS patients for the application for the PCI guidance. And by the year 2023, we can see once again the recommendation level for the unclear capillary lesions or the selected cases is level only 2A recommendation. So the question is that to what level and what day could we reach the recommendation of class 1A? So to get to there, we need to prove that intravascular imaging guidance PCI can improve the prognosis of the complex lesions, including the following details with multivessel disease, left main bifurcation, CTO calcification, CKD, etc. So we can see that by the year 2024, ESC guidelines, for the first of the time, they recommended to use the intravascular imaging with class 1 level A recommendation for the complex lesions. For example, like the left main disease, true bifurcations, lung lesions, etc. And this year, on January 2025, ACC/HA guidelines indicated for the complex lesions and the ACS disease to use intravascular imaging to guide the PCI. And I think that this is a very important recommendation with updated recommendation level for the intravascular imaging in our daily practice, not only just for the simple cases, but for the complex cases. So nowadays that we are happy to use the intravascular imaging. So the question to answer is that what are the key trials and findings that promote this kind of recommendation from the guidelines? And what's the definition of the complex lesions? Should we apply OCT or IVUS? Which one is superior to another one, or either one is fine? And finally, how to optimize, what's the standard of intravascular imaging guided PCI? So let me introduce several landmark studies that is introduced here. So before any landmark trials, let's check this meta-analysis published 2024 on the Lancet. Previously, the old meta-analysis only proved that the intravascular imaging can improve the prognosis with a composite of the MIS events, but hardly prove that it can develop the myocardial infarction or all-cause mortality. With this meta-analysis, we can include 22 trials with 15,000 patients that not only just include a single intravascular imaging mortality like OCT or IVUS, also included the study we can see use either OCT or IVUS compared with angiography-guided PCI. So the all outcomes indicated that either OCT or IVUS usage versus angiography-guided PCI can dramatically reduce the MACE event and the primary endpoint with a target lesion failure defined by the cardiac death, target vessel myocardial infarction, target lesion revascularization, etc. So dramatically reduces kind of target lesion failure by 31%, and also reduces the MACE event of stent thrombosis and all-cause mortality, as well as myocardial infarction. So with this meta-analysis, we can see that the intravascular imaging is superior to the angiography-guided PCI. And when we comparing the OCT-guided PCI with the IVUS-guided PCI, we can see that there is no difference among the two modalities that can be used. So once again, this kind of analysis indicated that OCT is non-inferior to that of IVUS-guided PCI. So let's move to the complex lesions. I'd like to use the Renovate complex PCI, this kind of trial, to introduce what's the definition of complex PCI in this kind of landmark trials. We can see that in the Renovate complex PCI, the definition for complex lesions indicated that including at least one of the following criteria, including the true bifurcation, CTO, unprotected left mean, long lesions, multi-vessels, etc. So we can see almost include all our challenging cases we can meet in our daily practice. So this is the real world practice that the cases we can meet. So let's come back to Renovate complex PCI, including 1,600 patients with complex coronary lesions. And we can see that include the left mean disease, CTO, bifurcation, long lesion, etc. So the primary endpoint is target vessel failure. We can see during the 2.5 years follow-up, at the median follow-up time, that we can see the target vessel failure in the intravascular guided PCI group dramatically reduced compared to the angiography guided group, with 70.7% vs 12.3%. And also the cardiac deaths and the myocardial infarction were also reduced. And another landmark trial that includes complex PCI is Illumine 4. We can see that we use OCT to get the PCI for complex cases, including 2,400 patients. The primary endpoint is a post-procedure minimum stent area and 2 years follow-up of target vessel failure. So this trial is applied during the COVID-19 era. So we can see that during the 2-year follow-up, we didn't find any statistical differences in the target vessel failure. However, in the OCT guided group, the minimum stent area is dramatically larger compared to the angiography guided group. So which I believe that in the longer follow-up will indicated that difference in the target vessel failure also proves that OCT is superior to angiography guided PCI. And let's move to bifurcation studies. We can see that October is very landmark studies to prove that in the complex cases like bifurcation, intravascular imaging can also bring the better prognosis for the patient. We can see include 1,200 patients with bifurcation lesions, OCT guided PCI versus angiography guided PCI with 2-year follow-up. We can see that the 2-year MACE event is dramatically reduced in the OCT guided PCI. Once again, indicated that in the bifurcation lesion, the intravascular imaging can develop the prognosis of the patients. Let's move to left mean disease. Left mean disease is a very unique and very important kind of lesions. Conventional studies, the follow-up time is not so long, maybe 1 year, 2 years, or 5 years. We hardly seen any long-term follow-up studies in the left mean disease, because sometimes we need to understand what's the long prognosis of the left mean PCIs. So this study, including 1,000 patients, that is published as in 2020, that using the IVUS guided PCI compared to that of angiography guided PCI, and the result after 10 years of follow-up, this kind of long follow-up. Also, we can see that the intravascular imaging guided PCI can reduce the MACE event of death occur myocardial infarction, and the composite outcome including the stroke, etc. So we can see even after the long-term follow-up, like 10 years, the intravascular guided PCI in the left mean disease is still promoting. Another very important thing I'd like to emphasize is that for the left mean disease, we can see that the intravascular imaging guidance is goes through the entire procedure flow, not only just the pre-procedure PCI to measure the minimum rooming area to tell you whether this may need to be treated or not. During the PCI, to make up the plans or check out whether it's a one-stent strategy or two-stent strategy, and post the PCI to guarantee for a good prognosis. And also the cutoff value after the PCI for a good prognosis in the Asian, relatively smaller person size, or in the European or for the white people is different. We can see that the cutoff value is slightly different. We should pay attention to this one. And there are also other complex lesions. For example, the long diffuse lesions. In this trial, IVUS XPL trial, the definition for the long diffuse lesion is a stent length over 28 millimeter. We can see compared to the IVUS guided PCI and angiography guided PCI with 1 year follow-up, the 1 year MACE event is dramatically reduced in the intravascular guided PCI. And the CTO, as we all know, that is a complex and difficult cases. And during the CTO cases, compared to the intravascular guided PCI, we can see that also dramatically reduced the primary endpoint and the secondary endpoint, including the stent thrombosis at 2 years, myocardial infarction, target lesion revascularization, and the TVR, etc. So we can see almost all the difficult kind of complex cases using the intravascular imaging can give us very promising prognosis to the patient. And another very unique type of lesion is calcified lesion. We almost meet this kind of lesion every day. Intravascular imaging, not only IVUS but also OCT, has their own, this kind of scoring systems to tell you what kind of modality should be applied. And we can see that either IVUS or OCT over the score of 2 that can predict incomplete stent expansion, which means that maybe active rotablation, this kind of modality should be applied, actively. And calcified disease, Illumin-4 with OCT guided PCI demonstrated that the OCT, guided PCI is associated with more aggressive procedure, higher atmosphere of post-dilation, larger balloons, and with a larger minimum stent area after the PCI, with a reduced target lesion failure at a 2-year follow-up. And also for the renal insufficient patients, intravascular imaging, especially IVUS usage, can reduce the amount of contrast usage, and also associated with a better prognosis, can lower the MACE event to the patients with no CKD. So once again, let's come back to this chart. We can see that during this kind of, with the gathering of the, promoting landmark studies, 2024 and 25, we have the guidelines recommendation to the class 1A. And like on year 2023, Akiko just mentioned that intravascular imaging will be mandatory soon. I think the future is now. To answer the questions whether we need to use IVUS or OCT or either one is fine, we can see that more and more studies like opinion Illumin-3 just prove that OCT is non-inferior to IVUS. So I think that for the daily cases, except for the left means or CTOs, OCT is a similar prognosis for the patients to usage. And OCT IVUS study comparing the efficacy safety of OCT versus IVUS guided PCI in the complex spaces. We can see the result indicates that either kind of modality is the same for the prognosis of the patients to usage. And let's come back to the guidelines in China. On 2025, the Chinese guidelines for percutaneous coronary intervention just updated to the recommendation level to class 1A, to develop the prognosis of the patients. Also, this year we can see that AI, artificial intelligence usage is applied in different kind of field. And also, we can see the Ultron system by the OCT from Abbott company can automatically measure the quantification of the calcium angle and also the maximum thickness of the calcium, as well as measure the length and the accurate size of the stent to help the operator to put the stent in. And also a Vigo system by the IVUS from the Boston Scientific can also help you to measure the lumen plaque burden as well as the length of the stent and help you to choose the right landing zone of the vessel in the longitudinal view. And also we can see that here with hybrid system from the second affiliate hospital, Harbin Medical University, from Professor Yuber's team, just indicated that we can use one catheter to make the image of OCT and IVUS at one time. And also our team, led by Professor Li Yue, that we develop our own tools for artificial intelligence usage in the clinical usage. For example, like the neural network-based, plaque progression prediction system, and also this kind of a CT-based reconstruction system that can help you to check the plaque composition distribution before the PCI procedure to set up the strategies, and also the CT angio combined FFR systems. And also based on the platform HS that we developed the consensus and the calcium nodule consensus, and will be maybe under review and will be published soon. So a little bit of summary. The intravascular imaging is of key importance in the daily practice, and nowadays that guidelines is reached to level 1A recommendation. So which means that in the daily complex lesions, we can use the intravascular imaging, which is promising to better prognosis compared to the angiography alone. And also maybe in the future that we can see, we will guarantee maybe over 90 or 100% usage of the intravascular imaging in our daily life. This is all I want to say today. Thank you. I'm happy to take questions. Thank you.